I always wonder whether we have actually figured out some of these parts of the brain, or whether we just think we know what we're working on, and maybe we just haven't discovered the Zeta receptor. So hence the title, because I've thought about that for a lot of years. Because I think my biggest guide point for my whole career actually was a professor who was literally, I believe, 90 years old, who was in the first week of my medical school. And he told the class that we were going to learn a lot of information in the 4 years we were there, and that 50% of it was incorrect. The problem was we didn't know which 50%. And I've lived my career with that mindset, that although there are experts who in certain areas, the expertise is only as good as modern medicine, modern science. That changes over time. You've all seen it change over time as well. Even discovering new anatomical parts of the human body that we really believed, I think, had all been discovered maybe even a century ago, they've in recent times. So just keep that in mind as we look at, it's not, let me move here. So let me just mention, just so you've all seen it again, you're all very familiar with this, but these are the 9 potential signs and symptoms of a major depressive episode, therefore disorder. But they have not changed from the DSM-4 to the DSM-5, now the DSM-5 text revision. So the net result of that is we still have to have 5 of these 9 for at least 2 weeks for somebody to get the official diagnosis of a major depressive episode. And I'm saying all that because when they do research, that is what's required. So they're not doing research on any, when we talk about depression, that's the research. It's on this set of criteria. And again, it hasn't changed. I didn't look at the DSM-3R to go back that far, but at least since the DSM-4, which is 1994 and beyond, these have been the criteria. So we've had a lot of good research over a lot of years using these exact criteria. The students often learn this as SIG-E caps, as in mnemonic for this, which gets through, sleep is S and lack of interest is number 2 and so forth. So the other piece I'll mention is that you have to have one or the other of these first 2, either depressed mood or anhedonia, the other word for the second criterion here, one or the other within those 5 out of 9, but you do not have to have both, which tells you one really important factor is the person does not have to endorse a depressed mood in order to meet the criteria for a major depressive episode or disorder. So just be aware of that. That comes up more for those of you who treat youth, because they don't necessarily come in saying I'm depressed. They may come in giving you other signs or symptoms that then will meet these criteria. So just be aware of that as we look at what are we talking about with the theories of depression and the article that we all had to read. And of course, the big issue ultimately is this last one here. We would love to decrease the American rate of death by suicide, which in the United States is one of the worst in the world. And it not always due to depression, but it is highly correlated in many cases with depression. And then, of course, we have a lot of antidepressant medications now. We're going to focus on the ones that deal with serotonin today, but just so you see this as a backdrop, so there's a lot of different medications. Some of them are used for anxiety disorders, right? So we know there's some overlap in the brain around how people experience things. Maybe I experience it as anxiety if I have a lower level of a certain neurochemical or something of that nature, whereas somebody else experiences that as depression. That's still part of the theory, part of trying to figure this out. But we do basically believe, and this is what we say to our patients, that there's a chemical imbalance in the brain, probably at the level of the synapse, that little diagram we used to have there, and there's this gap here. But that's what we really have thought about for all these years, and that individuals with major depressive disorder have a lower amount of the brain chemicals, any of the neurotransmitters we're talking about. Usually we're talking norepinephrine, which was the first one we acted on with medications going back to 1950 or so. Then serotonin, which started with Prozac or fluoxetine, if you will. And then we, of course, later thought about dopamine The only one that we have that raises that is Wellbutrin or bupropion. So that's the theory we've all lived with, certainly my whole career, and I suspect the generation of mental health people before me. We've really lived with that concept. And just to touch on this, so we have this range. I'm just giving you this as backdrop. We're going to talk about mostly SSRIs today. So those that increase serotonin and leave it in the synapse for a little bit longer. And by a little bit, I mean a nanosecond or two longer. By the way, we're not talking a long, long time. It's a little bit longer. But we have others. So we started with tricyclics. We have the dopamine reuptake inhibitors. The only one right now is bupropion. We have mirtazapine, which you may also know as Remeron, an alpha-2 agonist, very different mechanism of action, and makes people quite tired, so we tend to give that at bedtime. We've got a lot of new ones that don't quite fit any of these models. They often, however, do have action tied to the serotonin system, so these often fall into that system. We have MAO inhibitors, which nobody ever wants to talk about, but are actually very good for atypical episodes of a major depressive disorder. Usually that means that the person is eating too much and sleeping too much. So weight gain and too much sleep as the concept of an atypical major depressive episode. We know that some of these have issues with fermented cheeses and wines and can cause a hypertensive crisis. So that's, I think, why we've tended to avoid them, although there are some now that don't have that problem. And then finally, we have the SN, norepinephrine, which is really what we targeted back here in the 1950s and 60s, reuptake inhibitors. So just to give you the backdrop, because we've got a lot, the point of this is, and I'm going to come to this in full circle at the end, there's a lot of things going on that may help treat depression. And we tend to think serotonin hypothesis, but we already every day, all of us on this here talk with our patients, whether we're doing the psychotherapy and somebody else is doing the prescribing, or we're doing both, or just in quotes prescribing, we may be actually acting on all sorts of areas in the brain, not only serotonin. So just keep that in mind as we look at the article. And of course, focusing on serotonin for a moment, there's a lot of side effects potentially from serotonin agents. And so we don't want to forget that. And the reason for a lot of these, for example, in the gastrointestinal system, is there's a lot of serotonin in our gut, which basically has its own nervous system. So when you swallow and you get peristalsis, everything that carries that through your body really has its own innervation, and most of that is driven by serotonin. So when you take something that increases your serotonin, you may have these GI side effects. Many people have those. However, that system adjusts very rapidly because it's pretty rudimentary, and the net result is within 5 days usually that people don't have that GI upset. But of course, it's affecting the brain, so we have a lot of potential CNS effects, including dangerous situations such as serotonin syndrome, which whole nother lecture. Increased suicide risk still listed for youth, and so that we have to worry about that in terms of, does that somehow increase their activity more than their mood, and the net result is they act on their low mood because they now have the energy to do it and may make a suicide attempt. That's the prevailing theory. We know that it potentially sexual side effects because serotonin is tied to that system as well. Lots of things. And then we know not to mix them with the MAO inhibitors, again, because we may cause too much increase. So this is just the serotonin syndrome. I wanted to mention this for just the risk factor. I think we should always be talking about the safety of our medications. And, people with migraines may take a triptan. I think the first was sumatriptan, but there's a million of them now. Any of those can have a bad interaction. They also increase serotonin. So just be aware of that as we talk about the article. So the article is, I've actually never heard the phrase umbrella review, so I had to look that up and read a little bit about that. But basically, it's above and beyond a meta-analysis, which is often what we think about. And so they actually did a lot of criteria. When you look at the article, it's got multiple charts and graphs explaining how they decided these were the 17 studies. So just be aware of that. They've got a lot of reasons, which as far as I can tell are quite sound, but I'm not that level of a researcher to say yes or no to that. But it looks like they were making certain, because this is in molecular psychiatry, as you can see, and they really were trying to make sure they chose wisely and only included those studies that matched what they could actually put within the umbrella study. And so from that, they had 12 systematic reviews or meta-analyses. They had one collaborative meta-analysis. They had one meta-analysis of large cohort studies, one systematic review, which had some narrative in it, so some qualitative information as opposed to all quantitative, a genetic association study, which gets into some receptors, which we'll touch on here. And those receptors are the only thing on the quiz at the end. So pay attention to that. I'm kidding. And then, of course, there was another umbrella review included within this. If you add these up, you'll get 17 actual studies. And they did say that they did not, within this umbrella review, they did not take the results of individual meta-analyses and synthesize them together because they included overlapping studies, right? So my meta-analysis might have had some of the same studies in it that Nicole's meta-analysis did, and that would get confusing for the data. So they did not do that because of that. That's why you see them showing up in several places here, meta-analysis here, separate from these meta-analyses and so forth. So I tried to simplify the article into a few slides here, just to give you the basic information. And quite frankly, this is probably a pretty rare article in that they have a very large abstract, which pretty much covers what's in the article. The rest of the article is about how they selected the studies and then some of how they did the data analysis, which doesn't really help too much. And then there, of course, there is a little bit of an introduction, some of which I just touched on, talking about serotonin and a little bit of our history around treating depression. And then at the end of all this, as I said, we'll talk about the article, and then I will talk about all the other things, or at least many of the other things that have shown evidence for helping to treat depression, because I think it's very telling as to why this article, it shouldn't be all that shocking to us. But it's gotten a lot of waves, I can tell you, on my Maryland psychiatric listserv that I'm still on since I trained there, and other places, that there's a lot of, it's sort of like when Prozac came out, somebody wrote a book, I forget exactly the word, but something like talking to Prozac, and one was talking back to Prozac, kind of a point counterpoint type thing. And the same idea, we're pushing on the, wait a minute, what does this really mean? Should we stop using Prozac? Well, no, that's not what it means. I can say that for sure, but it means we need to be thinking about these things more broadly. So the two meta-analyses that were listed, and I highlighted them just to give you a sense of how many studies in each of these sections we're talking about, examined the metabolites. So again, most of these, we aren't doing autopsies on people to figure out what was going on. So we have to draw metabolites and chemicals out, or cerebral spinal fluid in some of these, to be able to figure out what are we measuring. So just understand that at some level, these are a proxy, which is not a bad thing, because most of this is theory, and then we're testing the proxy. My one dog is telling me that she has no idea what I'm saying. So no association with depression. So of these two, the largest one had 1,002 people. So the point being, pretty good sized study, and they could not find an association statistically between the metabolite levels up, down, or consistent with depression, right? So you compare the people with depression, you compare their metabolites, they're the same. Wow. Okay. We would have thought that the people with depression had a lower amount of metabolite because they had less serotonin to start with. They did not show that, just to try to put that in simpler terms. They had a meta-analysis of a whole bunch of cohort studies. They looked at plasma, so looking in the blood at serotonin levels, also could not find a relationship with depression. They did show, I say and, but I put but, lowered serotonin concentration was associated with antidepressant use, which is, I'll get to at the end. That's not what you're looking for, right? You're not expecting it to be lower when you use an antidepressant. And that again, pretty big study looking at that. Then they worked on 5 different studies that they rolled together in the data, 2 meta-analyses, and they looked at the 5-HT1A receptor, pretty good sized studies again, and then 3 meta-analyses of other overlapping studies looking at SERT binding. And I put a note because I had to look it up, so I figured so would most of you, other than maybe Dr. Dugan, some of these receptor points, and maybe Dr. Messamore, if he was on here, would understand this better than most of us. But so the SERT is, I mentioned MAO inhibitors. So monoamines are all of these neurotransmitters. So the monoamine transporter protein, so it takes the serotonin from the synaptic cleft back to the presynaptic neuron. So again, we've got I hope you can see my fingers here, my hands. So we've got that synapse here. And remember, the whole point of the SSRI is to slow down this system so the serotonin stays in the cleft longer, and then it acts on the receiving neuron. And literally under the electron microscope, we can see physical changes to the brain at the level of the synapse based on our medications, including the serotonin ones. So that's the concept here, right? So that this is how that transport, then it terminates the action of the serotonin because it's basically taking it back up, and then it's got a whole sodium channel piece, which is for me mostly nightmares of learning that way back when. So, but the point is very important here, so we understand what's going on, that they really are looking at that microscopic level based on these metabolites about what's going on with the 5-HT1A receptor and then with the SERT binding process. And again, it wasn't really helpful as far as, gee, this is not what we think, because weak and very inconsistent evidence of reduced binding in some areas. So is it changed? Are the medications really making a difference at that level? What is going on in terms of serotonin? Interesting, I think. By the way, the prior antidepressant use, which could be confounding to some of these studies, doesn't get calculated very well in most of the studies. So they just made an exclusionary point here that was not reliably excluded. So that could be still, even when you do a larger analysis, this umbrella analysis could also be a confounding variable in terms of the outcome of the findings here. They then looked at a big meta-analysis of tryptophan, right? So that's another one we hear about. You even hear about people taking over the counter tryptophan. You hear about tryptophan in Turkey during Thanksgiving. Oh, gee, that makes you tired. But the truth is, it's probably just because, I'll use myself, I overeat. And of course I'm tired because all my blood rushes down to my GI system. It's probably not as much tryptophan as we want to believe. It's probably massive amounts of turkey and stuffing and everything else. But so the meta-analysis, again, looking at this now, large study, it had no effect in healthy volunteers, and then weak effect in those with a family history of depression, smaller group that they compared it to. I mean, so we're again not showing what science would think we would find if serotonin is what should be, increasing serotonin is what makes a difference for treating depression under our largest theory, which has really stood sway for like 30 years. The systematic review here, again, all these are fairly good sizes, but rolled together, it's a lot of people. 10 other studies that they did, no effect in the volunteers. And so again, you're looking at this going, wait a minute, why are we not, this again is tryptophan, why are we not seeing this? And you can see there's been no other review since 2007 of these depletion studies. So I think these didn't work out, researchers stopped using them. So that was not a good indicator of the theory. So if they use these studies, they discovered, gee, we can't keep talking about the theory with serotonin if we keep finding equivocal or even opposite of what we'd expect to find, if you will, the null hypothesis gets found there. And then the two largest, and these are huge, notice the 115,000, the 43,000, and they looked again at the SERT gene piece, trying to figure out, was there some connection here? And they did a collaborative meta-analysis piece in there. No evidence of an association between the SERT, which again gets into the serotonin genetics, and depression, or the interaction between genotype, stress, and depression. So they looked at, and that's a lot of, that's pretty detailed. Now that's a study that couldn't have been done very long ago in the sense that we had not even fully sequenced the genome and all that. So they're really bringing in the most modern science that we have and reaching a conclusion, in this case, that perhaps the serotonin theory is not accurate, or it's not accurate for everybody. So in conclusion, for the article itself, and again, I'm happy to have discussion and questions, no consistent evidence of there being an association between serotonin and depression, which I think is quite the headline, right? USA Today or what have you. That's a pretty big headline, because again, for 30 years, really since about the time of Prozac, we've talked serotonin hypothesis for depression. No support for the hypothesis, therefore, that depression is caused by lowered serotonin activity or concentration. Mostly we mean at synapse. There is some evidence, unfortunately, that long-term antidepressant use actually reduces serotonin concentration, which gets into all sorts of discussions. So if you go back a little bit further in time, we used to do, even for depression, medication holidays. We would basically treat an episode of major depressive disorder until the person was doing well, and then we would stop it, maybe taper it and stop it, but we would stop it. Those studies that have been done in the past indicate, again, different studies, so different outcomes, but the simple version is, in fact, I use this when I talk to my patients, when they ask me that question, doctor, am I going to take this forever? So part of what I tell them is, well, the studies say that your brain will reach equilibrium and balance itself out even without treatment in 6 months to 13 months. That's the range of the studies. I just say 6 months to a year. And my recommendation to them is, well, if you were my own brother, I'd say wait a year, because you want to give yourself the best chance of not ever needing to go back into an episode of depression. Again, this is the person who really wants to stop it. And if you're really chomping at the bit to get off the medication for whatever reason, then at least wait 6 months until after you felt well. So that's usually my advice to, quite frankly, always my advice to patients when we get to that point. Sadly, what we've then learned, of course, is when people have more than one episode, certainly if they've had 3 episodes, we now tend, because the side effects are pretty minimal for most people, if you find the right version of one of these many medications, they just stay on it. And that may be a good thing. However, it may be that we're causing some of our own problem based on this last point, that we actually are decreasing it. So the person may then forever have to take one when they might not have forever had to take one. And that's a tough science to figure out. So that's the big overall. So let me stop there first before we